We have a quick correction as we welcome you back. Our guest before the break, Prof. Wendell Label, is from the UWI's Department of Psychiatry, not Caritox, where the research was done. So we make that correction. We apologize, Prof, for that. And now onto something amazing that happened right here in Jamaica. I mean, I'm talking right now to one of the people who was integrally involved, and I feel like I'm in the middle of a Netflix movie. It's called an awake brain surgery or awake craniotomy. Never been done before in Jamaica until it was done about 2 weeks ago.
Morning. Not exactly accurate. It's not just an awake brain surgery.
Yes.
It's an Axiem guided awake craniotomy where we use an electromagnetic pulse from a stealth image guidance that makes a whole bit of difference. So the Axiem...
Well, on the doc, I'm going to ask you what, but can I tell the people who you are first?
Sure.
We have the neurosurgeon that performed this groundbreaking procedure, Dr. Roger Hunter, to tell us more about it. And clearly you can see he's ready to tell us. So it's called an Axiem.
Axiem, A-X-I-E-M, stealth guided, where we use an electromagnetic pulse that sends a pulse around the head. And there's a little device that connects and integrates the images onto a computer screen, so it guides us at surgery. This is very, very pioneer, very cutting edge, and in fact quite pioneering for Jamaica. And what was particularly interesting with this case, he actually had a pulmonary embolus, a saddle embolus, and we had to fully anticoagulate him.
So we had to, please tell us in English.
We had to thin the blood. We had to be on blood thinners. Remember COVID?
Right.
Blood thinners?
Yes.
So can you imagine, we're doing surgery, we're cutting, and we're thinning the blood at the same time. So there is increased bleeding. And he's now awake. We kept the patient awake, so that's really important. Now it seems scary, but really and truly is not that scary. And to be honest, awake craniotomies have been around for thousands of years.
So why are we just doing it here?
What we're just doing is using a particular device that's very, very hard to come by, let's put it that way, very expensive, but it makes it a lot more tailored, a lot more accurate to the point. Because if you have somebody awake, you want to get directly on as quickly as possible, get to the target accurately, and get out.
So tell me how, so Daryl Ricketts, Butcher and Clarendon, felt fine. A couple months ago, he started to have debilitating headaches, started to impact his quality of life. He began to talk less. He lost partial motion on his left side. His son said, no, Daddy, this is not right. Went and found out that he had a tumor in the frontal right area of his brain. And Doc, this is where you came in, along with a team that worked on him.
Absolutely, want to look up.
Yes. So tell me about, so prep time was about 2 hours.
That's right. You have to, in fact, it's before that. There's also planning time. We're pre-plan. So you look at the images, load them on a scan, get the equipment in place. All of that takes like on the weekend before, so it's days before. So it's quite a lot of intricacy involved and putting the team together. And I want to put a big shout out to the team because it's really a highly technical team, people with varied expertise. And if you allow me to mention them, people like Dr. Mark Sanderson, consultant, big up at Mapen Hospital, people like Clement Smith, a very versatile scrub surgical technician who is also goes by the name Max Element. So maybe Anthony Miller can reach out to him. He's also an artist, performing artist from 2010. He's also a surgical tech. Really great guy to be in the team. Joanne Bryan, Trisha and Brown, the whole team at Art of Surgery. Really amazing team led. The nurses led by Nurse Edwards, Shaw Edwards. Really, really amazing team. I mean, there's so many people to mention, but I mean, these are the really key elements in terms of executing the surgery and do it successfully awake.
Take me through the process now, because I'm reading this story. I'm reading where the patient is saying, it's hot, that's hot. And then this part that gets me, after peeling back Ricketts' forehead and drilling through a portion of his skull, Hunter finally gained access to his brain. What?
That's right. Actually, the painful part of it is giving the local anesthetic. You know, like you go to the dentist, when you give the injection, the cocaine, it's painful, and then the pain goes. And that's the most painful part. Afterwards, there's practically no more pain.
Okay.
Because the brain itself has no pain fibers.
And that injection is administered?
Right to the scalp. So we using the image guidance system, we make it as small as possible. And that's the beauty of using Axiem. And that's the groundbreaking part. Axiem allows us to be accurate right over the point where the lesion is. We don't know what it is. We're waiting on the pathology. And so we get in. But what I'm saying is that the skin is the painful part. Once the skin is numbed, it goes pretty straight. Plus, we're giving him sedatives as well. That
because he can tell you what he's feeling as you go along.
Absolutely
So you were talking to him?
Critical, and that's the beauty of doing it awake. We have to talk to the patient. We have to see, as we remove the abnormality, in this case, the prefrontal lobe, we want to know that we're not intruding on delicate sensitive areas like the motor strip, which causes movement. So during the surgery, Dr. Sanderson, the nurse, will be communicating with the patient, squeeze my hand, lift your leg up, and so on and so forth. So that is critical to the awake. That's why you did it awake. In fact, 5 o'clock yesterday evening, I saw a 39-year-old who had a general anesthetic, was in ICU for three days, and woke up paralyzed. So that's why when you do it awake, you stop when there is, you see, you go very, and so there's this dynamism between you and the surgical team, and that's the beauty of awake. Plus, you go home, in fact, you can go home the same day.
Really?
Absolutely. So it saves time, it saves money, it's less expensive. In fact, this patient was on the government.
It's less expensive?
It is less expensive. If you think about it, 3 days in ICU versus no day in ICU.
True.
No day in ICU.
Yeah.
We're talking about a patient who is up and walking versus somebody who's paralyzed and having to be doing physiotherapy, seizures. In fact, that patient's tumor, they came to me yesterday because their tumor regrew with seizures. So we're talking about let us use the technology. And this is him walking yesterday. I spoke to him this morning. He's at home now 11, 12 days. It is going to revolutionize brain surgery in Jamaica, doing it awake, and we're reaching out.
This is the first of many more.
This is the first of many more, and we want to reach out to the government administered health sector as well. That we would partner with them because we can do these surgeries fairly elegantly in spaces that you wouldn't necessarily associate with smaller operative units that are agile.
And where was this done?
This was done at the Art of Surgery on Ripon Road, formerly the Ripon Surgery Center.
Right.
But Dr.
So we're not talking about a big hospital, but a well-equipped, safe facility.
Absolutely well-equipped, safe. We do have ICU monitoring just for a period of time, but the patient goes home so rapidly. They recover so rapidly. So we minimize side effects, complications, in other words, and maximize accuracy by getting the job done. Well, the actual surgical part was about 6 hours, which is about fine for an awake procedure. But before that, remember, we now having the preparation and then afterwards as well. But because this was a very special event, and we had a big up to the STAR team that was there, we had to make amends and accommodate them as well. Shemel Lemmy and the wonderful team, Miss Simone Morgan and big up Gladstone Taylor, they were all here. So this technical procedure is going to transform brain surgery. Every patient doing brain surgery, the first question, can it be done awake?
All right, Doc, we have to go to break. This is mind-blowing. Pardon the pun on mind and brain and all the rest of it. And that tumor weighed about 3 pounds?
I guess I was tired, but it felt like 3 pounds afterwards. It was maybe not quite 3 pounds, but it felt it was quite large and heavy.
Incredible.
Yeah, we hope and waiting for the pathology.
Big up you and your team, man.
Well, thank you. We give God thanks.
Art of Surgery.
Well, we work also in Montego Bay as well, and other sites in Kingston.
But if we touch base with Art of Surgery, we can find you.
Absolutely, Oxford Medical Center, Winchester Medical Surgical Institute. But again, this patient was on a government waiting list.
Yeah.
And we want to partner, and we want to also Jan Hokrit, the Pro Surgery Foundation. We're also looking to partner to see how we can get government patients done in these smaller, nimble centers, and it can be done.
I'm telling you, God bless our doctors. We have some amazing hands. The hands of a lifesaver here. Hold them up, Doc. Never likes to boast about his steady hands. These are the real steady hands. Thank you so much, Dr. Hunter.
Pleasure. Thank you.
Congratulations to you and your team. And good morning, Sir Delroy, wherever you are this morning. We hope you're feeling well. Neurosurgeon and CEO of Medical Strategies, Dr. Roger Hunter. Still to come, we're talking to the vintage fashionista, Lady Eccentric. That, stop and more after we return from Studio B. Second edition of News in 5 is next.